Good morning, everybody.
Good morning, everybody. Hi. Good morning. We're so happy to have some of you back this morning for our Q&A. And we're so fortunate today. We have Dr. Kohlmeier on here and Dr. Clarke as well to be able to answer any questions that we might have. So we have a few that have come up. And does Tylenol work the same as Forteo for hypopara patients?
Bart, you want to take that one?
Sure, I'll be, yeah, why don't we? All right, so welcome this morning, glad to be with you and glad to see there are some questions. So this is a very good question because the parathyroid hormone analogs, of course, potentially would have beneficial effects for people with hypoparathyroidism. Now, the question was specifically TIM loss, and I think the second drug mentioned was the NatPara?
Forteo.
Forteo. All right. So two, parathyroid hormone analogs, obviously, sorry, Forteo is a parathyroid hormone analog PTH 1 to 34, whereas the abaloparatide TIM loss is the PTHRP 1 to 34. So these are related molecules, but the issue is, would these interact with the parathyroid hormone receptor that we think mediates the action of PTH in general and PTH analogs also? I think in my experience, I think this is a reasonable approach if a person can't take or can't obtain other things. And of course, right now we're in a window of time where we don't have access to other FDA approved agents unless you're already on the special use program for NatPara. So I myself have had patients where I think if they can't get Forteo approved, potentially abaloparatide could be considered. Although the interaction with the receptors are different, I suspect the kinetics and actions would be slightly different, but theoretically these would work. To my knowledge, though, there's no clinical trials ever done yet that looks at this in detail. And maybe Lynn, I don't know if you know of anything going on, but I have not heard of anything looking specifically at abaloparatide to see its actions in hypoparathyroidism. So
I agree with everything you've said, and I think everyone on knows that if they were going to use these parathyroid products, they're shorter acting and you have to use them several times a day, and it's very difficult to get them approved. And so we're hoping to have better.
Yeah, I'd say the one advantage right now with the abaloparatide is cost is less than with teriparatide for sure, by about 5 or 6 fold difference. So in a person, if you had to pay out of pocket, I would certainly consider that, but it's still a very expensive treatment. So,
okay, very good. Thank you. And the next question or comment is ideas on hypoparathyroidism, hypocalcemic induced seizures, and living with this condition. What ideas might you have to help them?
That's a tough one. That is the question. How do you prevent these severe hypocalcemic effects? And the ones that affect you all day, which is the cramping, tingling, brain fog, but not take too much calcium and active D so that we have the side effects of renal problems. I think that having a lab slip available so that you can go to the lab when you feel that you might have a drop in your calcium, to have a provider that will follow you closely, and to just not ever let your calcium get less than 8.8, 8.5. I think that that's a start. Don't take any medications that also lower your seizure threshold. There aren't too many, but Wellbutrin is one, which is a great both anti-anxiety and anti-depression. It doesn't cause weight gain. So a lot of people like Wellbutrin. It's also used for smoking cessation, but that lowers seizure threshold. A very important medication not to be on, and any other medication that might lower calcium. And Dr. Clarke, if you want to add to that, that'd be great.
Yeah, I think those are all great answers and exactly what I would say too. I think if the seizure threshold is dependent on serum calcium primarily, or even if there is a pre-existing seizure issue that low calcium seems to aggravate or promote seizures, the key thing is to try to maintain serum calcium to an adequate level. And I suspect for different individuals, that threshold might be slightly different. So like Lynn said, if you can maintain serum calcium 8.5 to 8.8, that's a very good threshold to start with. You might have to make it higher, but one of the challenges we face, of course, is you can't just check your calcium when you want because you feel like you're going low. And, sometimes you are forced to go in to get it checked. In a situation where you weren't sure, but you're feeling like it's coming on, I'd say I would treat anyway and then find out later what the calcium was, because of course, sometimes it's very hard to tell what your blood calcium is. And I think the studies show it's as hard to tell what your blood calcium is as it is to tell what your blood sugar is based on your feelings. This is a big issue, and still no answer for the pumps, or I'm sorry, the monitors that would tell us what blood calcium is at point of care. We really need those. We're not there yet. So.
Okay. And then is calcium from diet, calcium-rich foods, less damaging to the kidneys than supplements?
Maybe I'll say a word or two here. So one advantage of the food calcium is the absorption is not quite as rapid as it is with a tablet or a gummy or a chewy or other source that's given as a supplement. So you get a smoother calcium absorption. The height of the calcium after the absorption occurs is less with food than it is with a tablet or chewy. So theoretically, you might be over time not having as high blood calcium as you would if you just took supplements all the time. Sometimes food is inconvenient, and of course, personal tastes change over time. You get tired of food or of the foods that have calcium that and variety is always good. So I think whatever you need to do to maintain serum calcium is kind of the primary target. How you get there is up to you, and you can experiment with different ways to do it. But I think certainly a mix of food and or supplements, if you need them, is a very good way to go. So.
Okay, good. And then somebody had asked specifically, do you know what would you recommend for vitamin D specific foods?
All right. Lynn, do you want to?
Sure. I mean, that's a hard one. We want to protect our skin, so we don't, recommend sunshine for vitamin D, but we recommend it for everything else with sunblock on. But I know this wasn't specifically your question, but once you put on even the weakest sunblock we shouldn't even buy, which they still sell, you're going to block vitamin D production from UVB light. And the darker your skin, the older you are, the more spots you have from the sun, the less D you make. So then, there are foods you can go on to the online and look at that. Some fish have a lot of D. It's just so variable that, especially, and one of my take-home messages for my presentation later today is the importance of keeping your 25 hydroxy vitamin D level up by taking vitamin D supplements, especially when you're on parathyroid hormone. So we need it anyway, but I think the best vitamin D is the one over the counter. Doesn't have to be the most expensive one. You never know in anything you buy over the counter if it's really in there. That's the problem. It's not regulated the same way as the FDA. The FDA is not perfect. We are very grateful for it. The good thing is it's fat soluble, so you don't have to split it up like your calcium in a HypoPARA situation. You could take it all at once. If you take it 3 times a week, maybe 5,000 units 3 times a week. I think that it's very important not to take too much, especially because we're really concerned about the calcium. But I think anything less than, Bart, you can give me your opinion on this, but 4,000 to 5,000 a day is very safe. It depends on the individual. And probably 800 to 1,000 might not be enough in a HypoPARA patient. So you can try in your diet, because it's always better to get it in your diet. I don't like taking supplements either, but the vitamin Ds are pretty small, so they're much easier than calcium. And they don't interfere with other medications like calcium does. Yeah,
I would agree. I think, vitamin D absorption and metabolism is so variable between people that it's very hard to give a single standard dose for a given age, even to say this dose will fit the needs of, say, 95% of the population. We can't do that because it's so variable. So what we do is we target a certain amount, and I would generally say 1,000 to 2,000 units in my experience with adults seems to be adequate to get a blood 25 hydroxy D level that's up in the middle of the normal range. Now, one of the problems with this too is the assays for vitamin D vary between different labs. And if you see me here and our normal range is 20 to 50 nanograms per ml, and then you saw Lynn later, her assay is going to be slightly different by a different assay method. What I tell patients is if they can maintain it in the middle of the normal range for their assay, whatever that assay is, that's what our target should be. It'll keep things more stable. And like you say, it's easier to achieve this through a stable supplement over time. Foods, there's only a few foods that have enough vitamin D to even say anything about. Certainly green leafy vegetables, egg yolks, liver, deep water, you usually see fish that are fatty fish, they have it. And that's about it. There's not many other sources you can get through food reliably. And of course, most of us don't eat most of those foods all the time or intermittently. So it's much more reliable with a supplement. And whatever you figure out your needs are, that I'd say I'd probably just stick with that and keep taking it.
Okay, and we're going to do one more question before we start your program, and it was really related to this. Might slow release be a safer option than regular supplement?
Yeah, maybe just because I started that one, I'll answer. I'd say yes, it would behave more like food in that sense because it's not being absorbed immediately or rapidly. So theoretically, the peak calcium in the blood is going to be lower than it would be with a standard 500 or 600 milligram calcium carbonate or citrate supplement. So you can do it that way. One issue with that is potentially maybe the peak level that's achieved with that is not where you need it. You need it higher. So these are, again, things you have to experiment with and see what happens and, decide, go from there. So.
All right, thank you.